screen here. All right. So first name I see, Dr. Christie. Are you there, Doc? Are you there? You there? Can you speak? All right. All right, Doc. Let's get to work. Like I said, today is a mix set. Nothing really specific per se. So let's get to it. All right, Dr. Christie, what do we see here? I see a lot of looks like neuro, right? Looks like neuroanatomy. And the question reads, interruption of which of the following tracks is responsible for the amenorrhea? So we have a patient with amenorrhea. Oh, it's studied in chimpanzees. Did you guys study the chimpanzee chapter at the end of the first aid? No? Yeah, make sure you look into it. And there's a rodent section too. I'm kidding. This has nothing to do with chimpanzees. People are like, oh my goodness, for real? Look, you guys, some of y'all thought for real?
I was getting crazy because
yeah, you're like, wait, what? I don't remember.
I read the whole book and I was like, what?
I never seen nothing about chimpanzees. Okay, I'm kidding. Okay, so Dr. Christie, interruption of which tract causes amenorrhea in this chimpanzee? Let's see what's going on with this chimpanzee. Endocrine Research Lab is investigating regulation of the hypothalamic pituitary axis, nice, in the brains of chimps. They found that administering high dose chlorpromazine, focus, caused difficulty initiating movements, increased muscle rigidity, and produce resting tremors. So Dr. Christie, what can you tell me about chlorpromazine? Have you heard of that before?
Yes, I don't. I don't remember. I think it's a muscle relaxer. I'm not sure.
Okay. Hold on. So caused difficulty initiating movements, increased rigidity. We got some tremors here. Okay. These animals did not respond to positive stimuli, i.e. food, had decreased cognitive ability, and the female chimps stopped menstruating. So can you put it together, Doc? Hypothalamic pituitary axis, chlorpromazine, Christie, initiating movements, muscle rigidity, Dr. Christie. What you thinking? Anything. Doesn't do anything. All right. Someone else want to help?
Yeah, I'm lost.
Yeah. E. I don't know what E means. That's not what I asked. I asked chlorpromazine.
I think it's antipsychotic.
Nice. It's an antipsychotic. Very good. Okay, good. So now, who said E? Who said E?
Me.
All right. You, Dr.
It's Guerra.
Just give me okay. Hey, Doc. So why did you say E?
Because tuberoinfundibular tract is the tract to produce milk.
Okay, you're not wrong. Can you elaborate, please? What do you mean produces milk? What hormone is associated with this?
Oxytocin.
Oxytocin, sure, but that doesn't produce the milk. What allows the production of milk? Anyone? Prolactin. If they ask who allows the release of the milk from the nipple, that's oxytocin. Okay. Release. All right. Now, we're thinking prolactin. Somebody said it's an antipsychotic. Who is this that said antipsychotic? Doctor?
Focus.
All right.
It's for schizophrenia. With bipolar disorders, maybe.
Okay, stop right there. You said schizophrenia. Schizophrenia is a disease in which you have too much or too little of what?
Okay.
What is it? Schizophrenia. Too much or too little of? Anyone? Dopamine. Schizophrenia is dopamine, too much dopamine. So guess what, guys? What do you think all treatment for schizophrenia should be? If they have too much dopamine, what should you do?
Block the dopamine.
Look at that, block the dopamine. So now can you tell me how chlorpromazine works? Of course you can. It blocks dopamine. Great. How is that related to prolactin? Can anyone tell me?
Because dopamine blocks inhibits prolactin production.
Boom.
Yes.
Specifically where? And now we follow the technique. Is it in the tuberoinfundibular tract? One doctor said possibly, so I'll hold on to that. What about the thalamocortical tract?
No.
No.
All right. Nigrostriatal.
No.
All right. And we're down to 3. Mesocortical, mesolimbic, and tubuloinfundibular. Which one could you eliminate?
Mesolimbic.
Mesolimbic is gone. Now we're down to 2. What do we do? Do you like A? Do you like E? Do you not like A? Do you not like E? Or do you not know what to do?
Cortical sounds more like the cortex. I wouldn't go with
it.
the cortex.
I will go with the A.
I love it.
It's E.
E.
Yes.
E.
Okay.
Very good. Very good.
Because.
All right. Go ahead. Because?
No. It's just because I was reading that kind of action in the cortical threat, but.
We're talking about prolactin. That's the only thing we were focusing on. Prolactin. So remember, everyone.
Yeah.
Dopamine.
Sorry, I messed with the question. I thought about chlorpromazine.
All right. So you see, everyone focus on the big picture.
Yeah.
Okay. I was mentioning that earlier today to another student. Do not focus on one detail. Look at the entire recipe. What are they throwing at me? They're giving me a lot of information. However, yes, prolactin is inhibited by dopamine. Does anyone know the hormone that stimulates prolactin release? We know dopamine inhibits him, but does anyone know who stimulates him by any chance?
Bromocriptine?
No, I said a hormone.
The hormone is luteinizant.
Hormone.
LH.
Hormone. No, not LH.
GnRH?
Not GnRH. That's LHFSH.
TRH.
TRH. Yeah. Nice. All right. Good.
I got a question about that today.
And me too. And that's why I'm bringing it up. It's the one and only question I ever saw. So please remember that one. Okay. So TRH. TRH stimulates prolactin. So I want to give you guys something. Okay. I want to discuss 1 or 2 things, and then we'll move forward to the next question. Tubuloinfundibular tract. That's the pituitary, right? We know that's the pituitary. We get that. Right? Prolactin is released from there. Dopamine inhibits. Good. Nigrostriatal pathway, okay, we all know is associated with Parkinson's, right? Substantia nigra. Yeah.
Yes.
Okay. Good.
Yeah.
Now, this is something that I find to be pretty interesting. I want you all to really know really well. Mesocortical and mesolimbic. I need you to understand the difference between the two. They both have the word tract. They both have the word meso. So what's the difference? One says cortical, one says limbic. Can anybody tell me what the limbic system is associated with?
Feelings.
Feelings. Like what feeling? Emotions. What else?
Emotions.
Feelings, emotions. Come on. It's all right.
The limbic system is the which one where you smell something and can you remember like
that's the hippocampus.
You can associate it, right?
Interesting. So based off of everything that you've all have said collectively, is this a positive thing or a negative thing? Mesolimbic. What do you think? Positive. Yeah. Remember the F's of the limbic system, right? Feeling, fighting, feeding, sex. Right? Exactly. So remember all the F's, which for the most part feels pretty damn good. That being said, if I see mesolimbic system and I said that stuff feels good, it feels positive, I want you to all remember that mesolimbic tract is associated with positive symptoms in schizophrenia. If I know that the mesolimbic system is associated with positive symptoms, then by default, what do you think mesocortical is going to be?
Cortex.
Negative symptoms. Positive symptoms, limbic. Negative symptoms, mesocortical. Okay. The reason why that's important is because if we start talking about atypical versus typical antipsychotics, which one goes to the mesocortical, which one goes to mesolimbic? And you now know that if I say your patient has schizophrenia and you give them a typical antipsychotic like haloperidol, it's going to specifically attack the mesolimbic tract because that's good for typical positive symptoms. Whereas clozapine, for example, would be great for negative symptoms, i.e. mesocortical. All right. Everyone got that?
Oh my God, you're a genius.
I selected, I looked for specific questions so I can give specific concepts that I find that it covers a lot of information. So please remember that, everyone. And thanks for the compliment, all you guys. All right. Next question. Nice job, everyone. I like that collectively. This is really good. Okay, man, we got more people coming. I love it. All right, let's see here. Let's see who's next. Let's go with, all right, Dr. Lulu. What it do, Lulu? Were you there? You there? All right, Doc, let's get it in. Which of the following effects of diazepam graded dose response curve does this antidote have? Ooh. Look at the answers. We see upward cause, efficacy, competitive antagonism. Oh man, potency, efficacy. By the way, guys, before we even get to this question, I want to let you all know that on YouTube, you can find a video that covers this information. Okay. I think I have it entitled Pharmacokinetics, Pharmacodynamics Made Simple. Dr. Lopez, USMLE on YouTube. Okay. Pharmacokinetics, Pharmacodynamics Made Simple. It's going to cover this information, but I'm going to cover it with you all today. All right. So Dr. Lulu, we're looking at the effects of diazepam on the dose response curve. Oh, I'm sorry. The antidote. What dose response curve does the antidote have? Ooh. So Dr. Lulu, without even moving forward, can you tell me what the antidote for diazepam is?
Flumazenil.
Thank you. Flumazenil. Hey doc, how does flumazenil work, more or less? More or less. I don't want specifics.
Antagonist.
It is antagonist. Okay. Okay. I like that. To what?
Channels of.
Okay. I'll take it. I'll take it. So it's an antagonism to, let's say, chloride channels, GABA, etc. It doesn't really allow GABA to do its job. I like it. I like it. Now, this is a big concept. Okay. We have something that's known as reversible versus irreversible antagonism. Reversible versus irreversible antagonism. I want you all to know that 90% of all drugs, okay, all drugs have to be, oh, give me a second, have to be reversible. Okay, 90% of drugs have to be reversible versus irreversible. Why? Because just in case an intern decides to give this patient a little too much of said drug, you want to make sure you can save this patient, right? Make sense? Okay. Which is why we have very, very few drugs that are irreversible. A classic one would be like aspirin or phenoxybenzamine. Okay. So with that being said, Dr. Lulu, you're still there, right?
Yes.
Okay. So with that being said, Doc, I just want to make sure that you remember that if you're not sure where they're going or what drug they're talking about, just know that more than likely it's going to be reversible. Okay. And I'm specifically saying the word reversible because I don't want to give away the answer. All right. Dr. Lulu, let's get it in. 42, ER, after his daughter could not arouse him from sleep, states that his father has sleepless nights. Mother died in a car accident. He OD'd on diazepam, which we figured, right, based off of the question. After intubation, they give him an antidote and he gets better. All right, so basically that was a waste of time. All right, Lulu. So what you thinking? What you thinking? What you thinking? If we know that this is flumazenil, and I don't know, maybe you read or maybe you didn't read in the chapter where they mentioned how it was reversible versus irreversible. What would you suspect? What do you think? Is it?
I believe that maybe it will be D.
No. I'm asking, would it be reversible or irreversible?
This is reversible.
Reversible. Great. So then, Doc, reversible, is that associated with competitive or non-competitive inhibition?
Competitive inhibition.
Nice. Competitive, doctor. Does that deal with Km or Vmax?
Km.
Yes. How do you spell? Okay, Vmax. How do you spell competitive? K-O-M.
K.
How do you spell Km? Well, K, right? Competitive, right?
Yeah.
Nice. So with that being said, Doc, would it affect the efficacy?
No.
No, because you said Km.
It's not Vmax, yeah.
All right. Would it cause a shift to the right in the apparent decrease in potency due to competitive antagonism? It says competitive.
Yeah, maybe this because it's competitive.
Sure. What about C, shifts to the left, increase potency?
No, it's not. No, increase the potency.
Good.
Yeah.
Downward shift because it decreases efficacy. Does it affect efficacy? You said? Yes or no? What did you say over here with E?
Increase the efficacy.
Yeah, did I say does it affect efficacy? And you said no. So then would it decrease it? No, because you said it doesn't affect it. You see?
Oh yeah.
Now we're down to 2, Doc. What are you gonna do? You like A or like D? Do you not like A? Do you not like D? What are you gonna do? What does your gut tell you? Okay, great job.
Good.
Okay, so everyone, again, I reiterate, watch the video that I have on YouTube, pharmacokinetics, pharmacodynamics. Okay, I will go into the difference between Km and Vmax. So what this means is, just from a conceptual point of view, 90% of drugs are going to be reversible, meaning they are competitive. They are competitive antagonists. K for competitive, K for Km, K for concentration. So there's an increase, they call it a shift to the right, but it's an increase in the Km, i.e. the concentration. You see, with competitive. See, and then they say Vmax. I'm like, well, Vmax is the other one, efficacy. Okay. Please remember the difference. Now, here's something I will give you all for those that, for whatever reason, I don't know, maybe if you don't want, you just don't want to watch the video. But please remember this. Km is irreversibly proportional to affinity and potency. Affinity and potency, which means that if affinity increases or potency increases, my Km decreases. Or vice versa, which in this case was the case, right? You ruled out, Dr. Lulu, that there was what was it, an increase in potency, right? There was no increase. There was a decrease in potency because Km increased. So if they ask, we know that competitive will have increased Km, meaning affinity decreases, potency, decreases. Okay, potency decreases. All right, got it? Clear?
Can I
Thank
will
you.
say that any direction of Km, the others will opposite?
Basically, yeah, that's what I'm saying. Exactly.
Okay.
Yeah. So that, I guess that's what this symbol, I was taught that symbol means irreversibly proportional. I don't know. That's what I was taught at my school.
Yeah.
But all right, excellent. Okay, please again watch the video. 90% of drugs. 90% of drugs.
I have a question.
Competitive. Yes, talk to me, doctora.
When we want to talk about efficacy, is Vmax.
Yes, efficacy and Vmax are, I don't want to say they're one and the same, but for the purpose of the boards, it means the same thing. Okay, Vmax and efficacy. So if you're looking for, oh, it's going to increase the Vmax, or it's going to decrease the Vmax, and you don't see Vmax as an answer, then look for the word efficacy. It's the same thing.
Okay, thank you.
Okay, excellent. All right, guys, nice. Next question. Let's see here. I want to go with Dr. Alfredo. Dr. Alfredo, ¿cómo se va?
Oh, yeah.
All right, nice. Let's get it in, Doc. So we got some drugs. Let's see here. Which of the following medications did this woman most likely start 2 weeks before this presentation? Well, what presentation are we talking about? And as I can see the drugs, it looks like psych. Now, here's something. Here's just something just to give this to you. All right, there's something that I noticed. When it comes to psych, and please tell me, you guys too, tell me that you've seen this too. When it comes to psychology, I've noticed if you're absolutely unsure what drug to give the patient, whether they are going crazy or they're depressed, you give them an SSRI. Ever seen that before?
Yeah.
Like, okay, well, wait a minute. If they're depressed, right, that means that they lack serotonin. So then you give them serotonin, they feel better. Excellent. Well, then what if they're anxious? Well, you give them serotonin. You're like, okay, but I'm not really sure what happened. I just figured, like, I don't know, maybe they had an excess of SSRIs and they're like, you know what, whatever, just give it to him, and he's crazy, let him just give it to him and make them feel a certain way. All right, get out of my office, right? I don't know what's happening, but if you're ever unsure, okay, if you're ever unsure, SSRIs is a safe bet, okay, for psych questions. All right, Alfredo, let's get it in, doc. So what did this patient take 2 weeks ago? 32, had a seizure. 32 woman had a seizure. She began a new medication. She's obtunded. Blood pressure is super low. Ojo. And EKG shows a QRS duration of, anyone know how long the QRS duration should be, more or less?
120 maximum.
That's a bit too much.
100.
It's like 0.10. seconds, 0.10 seconds. Okay. Which is clearly this is much greater than 0.10 seconds, right? Because it's 170 milliseconds. So the point is, Dr. Alfredo, we have a patient who has seizures, hypotension, and QRS prolongation, and it's associated with an antipsychotic. I'm sorry, an antidepressive drug. What drug for depression causes seizures, hypotension, and QRS prolongation?
Sounds like a
Say it.
TCA.
That's what I'm talking about. Which of the following is a TCA, Doc?
The C.
Excellent. Okay. TCAs. So when it comes to TCAs, this is how I had it understood. Let me come over here. So yeah, when it comes to TCAs, what they tried to do was, oh Lord Almighty, give me a second. Close this. Okay. All right. TCAs were one of the first antipsychotic drugs, and then they came up with the SSRIs, and you ask yourself, well, why come up with SSRIs if TCAs were working pretty well, right? Here's the problem. Dr. Alfredo, how do TCAs work? Do you know? What's like the main thing, the main thing that they do?
I don't recall at the moment.
Okay, well, I'm not asking specifics, just logically speaking, the patient is depressed. So what should a TCA logically do? If he's depressed, it should bring him up. Yeah, should bring him up. He's down, bring him up. Using which neurotransmitters? Do you know?
Norepinephrine.
Norepinephrine and
Serotonin.
serotonin. Good. Serotonin and norepinephrine. Oops. Okay, good. Here's the issue. If it was just that, excellent. We would continue moving forward. Life would be good. SSRIs would never even be a thing. But I need you to remember the A's of the TCAs. Anyone ever heard of that? The A's of TCAs? No, you never heard of that. The A's of TCAs. So the first A is for alpha 1 inhibition. Alpha 1 inhibition. The second A is for anti-cholinergic side effects, right? Hot, dry skin, hot as a hare, dry as a mouse, mad as a hatter. I don't even know what a hatter. What is that? Does anyone know what a hatter is? Anyways, some of these mnemonics are so dumb, but you get it, right? Anticholinergic, hot, dry skin. Right? The other A is AV node, AV nodal blockade, and for that reason, arrhythmias. Look at that, another A. Thank you. You see? So therefore, this is the reason why there's prolongation of the QRS, because we had heart defects. Why is the blood pressure so low? Because alpha 1 was blocked. Why do they have seizures? Because it has too much serotonin and norepinephrine. See?
Yes.
So what do you give to treat? Because they will ask this. You give them sodium bicarb. In the book, it says, in the first aid, it says that TCA is a base. And if you overdose on a base, it wouldn't make sense to give you more base. But I was taught, aside from the first aid, I was taught that TCAs are acid. They're acidic. And that explains why you give sodium bicarb. You see that? Aspirin is acidic. That's why you give sodium bicarb. Make sense? Got it? Okay, good. All right.
So the correct QRS is 0.06 seconds?
0.10 seconds. 0.10 second. Here's 170 milliseconds.
Okay.
That's all. Okay. But very good. Now, SSRIs. So now, oh, this is good. This is good. So everybody got this, right? Because I'm going to move on to the other drugs. All right. So now, SSRIs, okay? Mad Hatter originates from Alice in Wonderland, where hats makers went, oh, okay. Thank you, doctor. I did not know. Apparently,
Sorry.
Alice. No, thank you. I didn't know. Because I'm like, I don't know what a hatter is. I have a hat. I don't know what a hatter is. Thank you. I appreciate it.
You're welcome.
I appreciate it. That's
Cultura
good.
general.
Hey, I didn't know that. Thank you. Okay, so let's SSRIs. The side effect of SSRIs. This is unique right here. SSRIs. Let's talk a little bit about this. I may have spoken about this before. So let's talk about serotonin, everyone. Okay, I'm just going to put 5-HT, serotonin. So we said that serotonin is usually given for people who are depressed, right? Because we want to bring them up, right? So essentially what we're trying to do is give them a sympathetic effect, right? Here's the thing. Does anybody know of a tumor in the GI tract that releases serotonin?
Carcinoid syndrome.
Nice, carcinoid syndrome. In carcinoid syndrome, does anyone know the presentation of carcinoid syndrome?
Wheezing.
Flushing.
Diarrhea.
Yep, flushing, diarrhea.
Wheezing.
Yeah, wheezing, bronchospasm.
Tricuspid regurgitation.
Excellent. And right heart failure. All right, everyone. Who is your best friend from the Dominican Republic that you love so much?
Dr. Lopez.
This guy. All right. Good. Best friend from the Dominican Republic you love so much. BFDR, bronchospasm, flushing, diarrhea, and right heart failure. That is carcinoid syndrome. Now, here's my question. Didn't we just say that serotonin is given to increase sympathetic effects, right? Bronchospasm and flushing and diarrhea. Does that sound sympathetic or parasympathetic to you?
Sympathetic.
Bronchospasm, flushing, and diarrhea?
Parasympathetic.
Parasympathetic. Okay, so this is parasympathetic. But didn't you just say that it was sympathetic? Unless there's a little catch. In the CNS, it is sympathetic. And in the PNS, it is parasympathetic.
Oh, yeah.
Please remember this, everyone. Super high yield, super high yield. Because if a patient comes in with too much serotonin in the brain, I'm not going to give them the same drug that I would give to someone who has too much serotonin in the GI tract. Which would be which drug, by the way? If a patient had carcinoid syndrome, how would I treat?
Somatostatin or
Somatostat. Say.
Somatostatin.
Somatostat analog. Octreotide. I love it. I love the accents. So octreotide. Let me see. Is it? Uh-oh. What happened here? All right. Octreotide. Very nice. Let's make this a little bit bigger. But if a patient had serotonin syndrome, maybe they were mixing MAOIs and SSRIs, would I give them octreotide?
No.
No, but it inhibits serotonin, right? So then what would I give them? Ooh, anyone know?
Sodium bicarbonate.
Nice try. Cyproheptadine. Cyproheptadine blocks serotonin in the CNS. Octreotide will block serotonin effects using somatostatin. But what if it's a patient who's vomiting a lot? Remember, serotonin is associated with vomiting too. Maybe a chemo patient. What drug can you give for that one? That blocks serotonin. Ondansetron.
Ondansetron.
Dan, how does it? Cetron? How do you spell that? Dansetron?
With an S.
With an S. Dansetron. All right, ondansetron. When you're feeling queasy on the dance floor, get your dance on with ondansetron. Got it? When you're feeling queasy on the dance floor, get your dance on with ondansetron. That's how I remember it. All right? Notice something though. Both drugs that begin with the letter O are down in the PNS. See?
Yes.
So they say cyproheptadine, CNS sympathetic. That has to be up here. You see? Okay. Here's another one. Who drinks coffee?
Me.
Right now, Doc. Right? Got it in right. Got to get in right now. Okay. Why do you drink coffee? Because you want this. you want the sympathetic effects of coffee, because coffee, by the way, can increase serotonin's effects. So by increasing serotonin, you have more sympathetic activity. Here's the problem. Doesn't that coffee eventually make it down to the PNS?
Yeah.
Yeah. And then what happens?
Tremor, diarrhea.
Diarrhea. Or at least urinate, right? Because it's very parasympathetic. Okay? All right. Everybody got that? That was a big concept. I really wanted to make sure everybody got that one. Okay. I hear you eating snacks. It's good. Enjoy the show. This is good. This is good.
I'm sorry.
No. I'm saying it's good. It's good.
I'm talking.
So, no, please. See, keep eating. So we have TCAs, right? We spoke about TCAs. We spoke about SSRIs. We understand how they work. And then for the MAOIs, again, they also, MAO inhibits catecholamines. So by blocking it, I can't inhibit catecholamines. So I increase catecholamines. All right. So I want you to remember this when it comes to MAOs. Give me a second. Let me come back over here. When it comes to MAOs, I want you to remember this mnemonic here. It's let's see, it was phenyltranny, iso, and was it iso and PITS, and selegiline. And selegiline. Phenyltranny, iso, selegiline. Phenyltranny, iso, selegiline. There's a mnemonic, it's like PITS, which is okay, but for some reason, phenyltranny, it's easier, rolls off the tongue easier, and then just iso and selegiline. Okay.
Yes.
Yeah. Can you repeat?
Finally, I learned them.
Right.
I just learned them.
Okay, that's good. Phenelzine, tranylcypramine, isocarboxazid, and selegiline. Just remember phenyltranny, iso, and selegiline, and you'll be good to go. Okay, because there's some crazy, it's funky names. Isocarboxazid is by far my favorite. I'm like, whoa, what is it? What are you? Okay.
Yes. Isocarboxazid.
Isocarboxazid with a Z. They got everything. Oh Lord. Okay. Good. So we continue. That's just something I wanted to give you. Thank you everyone for participating. Super great. Super good. Super good. Oh, Fernando is looking at you. He's looking at you. Pedro. He's looking at you. What you do, man? Are you there, Dr. Pedro?
Yes.
Oh, here we go. Diagnosis. Ready to go?
Yes.
All right. Here we go. So clearly it looks like maybe some GI. Maybe GI, maybe not, right? Not too sure. But we definitely know that this guy is upset, whatever it may be. He's not happy about it. All right, Dr. Pedro. 3 weeks ago, we got a guy who came back from India, young African-American man, comes in complaining of fevers, chills, and headaches. Okay. Blood smear stained with GEMSA is positive. Physician determines the diagnosis, gives him mefloquine. All right, Dr. Pedro, what do you think is going on so far? India, African-American, fevers and chills. Oh,
a viral infection.
Okay, viral infection. He was in India.
Malaria.
Malaria, fevers and chills. You're either chills or you got fever, but you ever get fevers and chills? I want you to immediately think malaria.
Okay.
Okay, and then they gave him an anti-malarial drug. Good. However, several weeks later, he returns complaining of a relapse. Although he did experience temporary improvement. The physician prescribes another drug and he comes back again, feeling fatigued, complaining of a change to the color in his eyes. What's going on here?
He has jaundice.
He has jaundice. There's a bilirubin issue. There's jaundice. He took mefloquine. He said it worked, but it didn't work. So he came back. He took another drug for malaria.
Maybe it's
maybe he has
Say it.
G. I don't even know how. Like I need to read it. If you can scroll down.
You got it. Good job. He has what? Say it again. Say it one more time.
Glucose 6-phosphate.
Thank you. It's the only one that says G. Only one that starts with the letter G. Come on now. Killing it. Good job, man. Glucose 6-phosphate dehydrogenase deficiency. G6PD deficiency. So this
it can be fava beans. It can be
some bad
medication.
habichuela or sulfa
Yes.
drugs, right? Or
Mhm.
frijoles, however you
Yes.
guys pronounce it, right? Bad beans. Okay. Good. So this opens me up to biochem. Okay. I want to discuss something here. Let me expand this. I thought this was already expanded. So we have a patient with G6PD deficiency. Okay. So if I have G6PD, what is G6PD associated with? Which metabolic pathway is G6PD associated with? Anyone know that one?
HMP.
HMP. Oh, okay. Yeah, HMP shunt. HMP shunt. Okay. Which is the initiating substrate? Who begins the HMP shunt? What's the substrate that begins the process, the pathway?
Glucose 6-phosphate.
Look at that, glucose 6-phosphate. All right, and what is the end product of the HMP shunt? What is the goal? What are we trying to get? Anyone? What are we trying to get? It's a rate limiting enzyme and my product. Anyone? Anyone? So we want to get ribulose 5-phosphate and NADPH. Not NADH. That comes from many other pathways. NADPH specifically comes from HMP shunt. Okay, what does that mean? This means that, or not what does it mean, but rather, why do I care?
This is will influence the electron change.
That's NAD. That's NADH,
Oh, yeah.
not NADP. That's why
NADH,
on the
yeah,
P.
sorry.
All right, so it does, I think, 2 or 3 things, if I'm not mistaken. First thing that comes to mind, purine, or DNA rather. Let's just be very generic. DNA synthesis. Remember, the very first step for purine synthesis, adenine and guanine, is ribose 5-phosphate. So as you can see, HMP shunt plays a big role. What else do I need the HMP shunt for? I need it for fatty acid synthesis with the help of NADPH. And I need it for my red blood cell life, right? Integrity.
Mhm.
Meaning, if I don't have NADPH, well, then my red blood cells are going to lyse.
Yeah.
Can anyone tell me why? Why, if I don't have NADPH, why would the red blood cells lyse? I think I put this like an image or a question up a few weeks back. Here's my red blood cell. Anyone know why?
It's because oxidation.
Okay, I'll take it.
The membrane.
I'm sorry.
Keep talking. Bring it.
Oxidative
Forces the hemoglobin to the nature
damage.
and form like a precipitants. I don't know if I'm going too far.
You went that way. You went that way. Come back. Come back to this link. Come back to this.
Oxidative stress.
Thank you. Oxidative stress. Okay, so basically you're telling me that, you're telling me that oxidative stress, right? Free radicals is causing damage. Here's the thing though. What does NADPH do to prevent this damage?
Because it converts oxygen to oxygen radical.
Oxygen free radicals. All right. It does. Sure. Anything else? The NADPH. Say it. Helps. Say it. Finish that sentence.
It helps reduce glutathione.
That's what I'm talking about. You guys are killing it today. So the red blood cell has this membrane. It's not really a membrane, but I think of it like as like a force field or a shield, right? And this shield prevents oxidative damage from occurring. The thing is, this shield needs the H. And who's going to deliver the H? NADP. And where does it come from? HMP shunt. But if the enzyme is deficient, guess what? I can't deliver the H. I can't reduce glutathione. And for that reason, glutathione doesn't work. Free radical damage. Dr. Pedro, if I were to give you a book bag full of heavy books, H for heavy books, and I said, here, take this. wouldn't you also be reduced, right? You're like kind of hunched over, right? Got his heavy book bag. Remember all that
Yes.
from high school, everyone, right? More or less my age. Nowadays, I don't have books, but yeah, we used to have big textbooks, right? So when you would walk around, you always be hunched down, reduced. And then what's the only thing you wanted to do? As soon as you got to class, you threw that damn book bag on the floor, right?
Yes.
Why? So you can oxidate yourself,
Stretch.
breathe.
Right. Mhm.
So to be reduced is to have the H, the heavy book bag. Okay. To be reduced is to have the H, the heavy book bag. Meaning if I give the H to somebody else, I have now been oxidized, but that other person has now been reduced. Does that make sense? This is what FAD does, NAD and NADP. That's what they do. They literally just deliver one heavy book bag from point A to point B. That's it. Okay. Now, let me see here. Is there anything else I want to say about this? G6PD deficiency. Okay, one last thing. We have a test called the nitro blue tetrazolium. Yes, everyone know that one, nitro blue?
Yes.
All right. So let me come over here. All right, so we have the NBT. Nitro blue and there's another one, dihydrotamine. Okay, everyone, pay close attention here. Nitro blue should turn blue. This is normal. If you're normal, if you're healthy, nitro blue should turn blue. Dihydrotamine should turn green. Dihydrotamine should turn green. This is normal, me and you. I don't think any of us have NADPH deficiency, so. Okay, nitro blue turns blue. Dihydrotamine turns green. So if it doesn't turn blue, and if it doesn't turn green, you have the disease. G6PD deficiency.
It would be negative.
That's the issue. I don't want you to think of it that way. Don't think it'll be negative or positive. That's the problem with that, because it says it doesn't turn blue, so it's negative on the exam, which means you're positive for disease. Or is it a positive on the exam, a negative for disease? Some people like that. Nitro blue turns blue. If it doesn't, you're sick. Dihydrotamine turns green. If it doesn't, you're sick. Period. Now let's say, what does that mean? That means I don't have the enzyme. Oh. Okay, that's how I want your brain to think of it, because that shit used to confuse me. Like, it's negative or positive, and it confused all my students. I did not like that. All right, so great job, everyone. Told you this is a nice one. This is a nice class for today. All right.
For example, in this case, the guy has like all this bilirubin because of destruction of the erythrocytes.
Yes. Yes.
Like the bite cells or.
No. Well, yeah, there's bite cells too. Yeah, there's bite cells and there's Heinz bodies.
And a lot of reticulocytes, maybe.
Yeah, of course. Yeah.
Okay.
But that's more of a heme connection, but really nice, really good. This would be more of a peripheral hemolytic anemia.
Okay.
All right, let's go with Dr. All right, Dr. Brenda. Let's do it. I think I was just talking to you, right?
No.
All right. All right, Dr. Brenda. At this time, the patient is at increased risk for developing which at this time. So it's 4:49. This patient is at increased risk for developing which. We have little old lady comes in. She's found in the park, lethargic. All right, older person, lethargic in the park, having trouble sleeping.
77-year-old.
Recently admits to taking a sedative that was prescribed for her husband, who's being treated for alcoholism. Interesting. She says the medication has helped her with sleep disturbance, allowing her to sleep throughout the night, which is good. However, she says she's having a hard time getting out of bed in the morning and feels sluggish. Patient speech is slurred. Pulse, not too bad. Respirations are all right. Blood pressure's a little low. I'm sorry, a little high.
Higher than 90.
And when asked to walk across the room, she stumbles and is uncoordinated. All right, Doc, what's happening here?
Well, I think it's a effect adverse of the medication of the husband that he takes for the stop drinking.
Good. So what medication would this be? Do you know?
I think maybe.
Benzo?
Maybe a benzo.
Oh.
Yeah.
Yeah.
Think of it like this, guys. Think of it like this. She says she has trouble sleeping, correct?
Yes.
Okay, so that means that she has a lot of upper or a lot of downer. Is a lot of up or is that a lot of down? What's going on?
Down.
It could be
If
no.
She's
try
up.
Pause. Listen, she has trouble sleeping. Is it too much up or too much down that's going on?
Too much up.
Too much up.
Too much
Too
up,
much up.
meaning the treatment should be
A
Down.
downer.
down. And
Okay.
guess what happened? She has a hard time getting out of bed in the morning. Maybe I gave her too much down.
Down.
Yeah. Great. So doc, if there's too much down, which of the following could be a potential side effect or increased
Right.
risk?
Respiratory depression.
Sounds
Yeah.
good to me. Sounds good to
Yeah.
me. See that?
Yeah. It's benzo.
Mhm.
Excellent job. Respiratory depression would have been a good one. Cardiovascular collapse could have been another one. Yeah, it just slows things down, right?
Mm.
Very good. Remember, benzos and barbiturates, they both increase GABA effect, okay? Benzos and barbiturates. Now, what's the difference? Nice and easy, everyone. We're all adults, yes? Yes, we're all adults. Ben is the name of a boy, and boys, men, like sex that more frequently. Ben likes sex more frequently, Ben, right? Whereas Barbie, girl's name, prefers sex that lasts longer duration, all night long is what I would hear. Okay? So, barbiturates, duration increases duration. Benzos, Ben, frequency. Either way, you're still going to get GABA effects. Okay? Good? Got it?
Yes.
All right.
Yes.
Nice. In one of the earlier videos that I think it was maybe last week, or I'm sorry, yeah, last week or 2 weeks ago, I think I discussed the GABA effect. Everybody remember that one? Anyone was present for that one? The GABA effects? Anyone?
No.
Anyone that was part of it prior, before? GABA effects? Anyone? Dr. Boo? Oh.
Yeah, GABA is inhibitory.
Uh-huh. I get that. But do you remember the concept that I described?
Oh, and that's why when you eat a big meal, you're yawning and things like that?
Okay.
Okay.
Nice try. Yeah, you got some of the examples.
Well,
all right, so
maybe
I'm listening.
like which one are deficient in GABA or have feelings of anxiety or stress, like the craving of alcohol?
No. This was something. No. I'm asking just specific GABA.
Like the lights out.
Say it again.
Like lights out. You mentioned.
I'm sorry, I'm not understanding. Lights out? I don't know what happened there. Okay, everyone, pay attention. Pay attention, please. GABA shuts off the lights. GABA shuts off the lights. Boom, lights are out. Okay, that's what he does. He's inhibitory. He shuts off the lights. So if there's too much GABA at the level of the brain, sedation, lethargy, somnolence, tired, confused, okay, mental depression. If I shut off all the lights in the heart, bradycardia, heart block, low cardiac output. If I shut off the lights in the lungs, respiratory depression, which is what you just said earlier, doctora, right? What about in GI tract? Constipation, they're not pooing. Incontinence, they're not peeing. Hyporeflexia in the muscles, because I'm shutting off the lights. Are you everybody following the concept?
Yes.
Okay. So the real question is, what stimulates GABA? Well, this is the concept I gave you all. Hydrogen acid, or CO2, which means acid, okay? Urea and ammonia, okay? These four rather, can and will stimulate the creation of GABA, okay?
Yes.
So when we get our pass, right, on the step, I'm sure you're gonna celebrate. Some people have different vices. Some people like alcohol. Alcohol is an acid. Have you ever seen somebody somebody drunk, tipsy? Yeah, slow, lethargic, right? Inhibitions are all low, sleepy, sometimes on the floor. Hey, Theo, right? That's my uncle. Yeah, that's it. That's GABA. Right? What about urea? Remember that the kidneys metabolize urea. So if I have renal failure, boom, it builds up and you have uremic encephalopathy.
Yeah.
Okay. Or ammonia is metabolized by the liver. Well, if I have liver cirrhosis, now I have hepatic encephalopathy. Somnolent, sleeping all the time, rings a bell. My child's very sleepy. I don't know what it was. I don't know. He had a fever. I gave him some medication that I read on Google, aspirin, Tylenol. Calls Ray syndrome. Yeah. All of a sudden he's very sleepy and he's not eating. I don't know what's going on, Doc. You're a terrible parent. That's what's going on. Google Docs. Got it? All right.
Yes.
Good. So that's the concept. I went over the concept again in one of the other many videos. So please check them out. Okay, guys, let's keep it moving. Let's move on to, I got a lot of people here. I like that. All right, let's go with Dr. H. Navedo.
Here, Doc.
All right, nice. Hey, Doc, how's it going? All right, so here we see a little bit of micro. Okay. So I've given this before. Some of you are my students. So does anyone remember how I gave you all 3 mechanisms of actions for antibiotics? Does anyone remember that? 3 mechanisms of action for antibiotics. Anyone?
As for membrane action in the membrane.
So far, that's one. So cell membrane attack.
A synthesis.
Protein.
Synthesis. And
nucleus. I guess I don't remember.
I'll take it. DNA. Synthesis or replication. Yes. I love it. Okay, everyone. So what does this mean? This means that if we're looking at antibiotics and they ask us mechanism of action, the first thing I want you to do, instead of trying to remember a specific drug associated with a specific bug, which is very difficult, by the way, I say just organize it. Say, does it affect the cell membrane? Does it affect the protein, or does it affect DNA? So if I say penicillin, you say penicillin. Oh, that's a cell membrane inhibitor, right? Right. But if I say erythromycin, like, oh, that's protein synthesis, right? If I say metronidazole, like, oh, that's DNA synthesis. Yeah, you see? Or how about this? I say your patient has a strep infection. You say strep. Well, does strep have a cell membrane? It does. So then I'll give them a cell membrane inhibitor like penicillin, ampicillin, right? Cephalosporins. But let's say you have a patient with a mycoplasma infection, right? Walking pneumonia. Does mycoplasma have a cell membrane?
No.
Oh, so I can't give them a cell membrane inhibitor. They say vancomycin. I'm like, no, get out of here. Got to be a macrolide. Right? That's what it is. Or what if it's like a really severe fungal infection like PCP pneumonia? Like, well, can't give them an antibiotic per se, but maybe I give them TMP-SMX and just inhibit DNA altogether.
Yeah.
See? Okay, good. That is how I want you to organize this, everyone. Okay. All right, Dr. Navedo. So with that being said, if I quickly look at the answer choices, I see that F says protein synthesis, E says protein synthesis, D says cell wall, C says cell wall, B says cell wall, and A says protein. So clearly this is going to be either one or the other, right?
Yeah.
There's no DNA. All right. All I need to hear from you is this is cell wall or protein. 19-year-old, mechanism of action of the antibiotic that was given. All right. So 19-year-old guy, construction worker, South Cali, comes in. He has acne vulgaris. Oh, that's the heavy stuff. That has only mildly improved with face washing, topical antibiotics. All right. He's had numerous papules and pustules, erythema on the face, neck, chest. Okay. Yeah, he's been taking oral antibiotics that's commonly used to treat acne. They're similar patients. He agrees to take a medication as prescribed and continues his routine of working long shifts on the construction site. So that's 2 times that they mention construction, right? Dr. Navedo?
Yeah.
Yeah, it's 2 times that they mention it. Interesting. 4 days after he starts taking the medication, he has these severe blisters on his face, back, his neck, and the back of his hands. WTF.
Yeah.
Yeah. What's going on here? Construction worker, working long hours. He has acne, and they gave him a drug. Now, I'm sure we've all had acne. Personally, I've never had to take an antibiotic for acne. So with that being said, Dr. Navedo, how many antibiotics do you know of are given for acne?
Well, if it's topical, it would be a step therapy, como escalera. I mean, the most common that I know it's Clinton and benzoyl.
Okay, that's the right. That's the topical stuff. You're right. But we're talking about now an oral antibiotic, so something significantly stronger than that. I agree. Yeah, the benzoate, that's the Neutrogena stuff.
Probably doxycycline.
Doxycycline. Yeah. Okay, so there it is. Doxycycline. Is that cell wall, DNA, or protein?
Protein.
Protein, meaning cell wall's gone, cell wall's gone, cell wall's gone. Do you see by organizing it, look what happened? We're down to 3 possible answer choices. And you said doxycycline. Does doxycycline inhibit 30S or 50S?
There is.
Done.
30.
Now we're down to 2.
30.
Now we're down to 2. Irreversible or reversible? What do you think, Dr. Navedo?
Well,
90% of drugs.
Reversible.
Amen. Thank you guys.
Yay.
90%, even if you're not sure. I didn't read that. I know you didn't read that because 90% of them, it's a concept. Okay. Muy bien. Now, if they want to be really detail oriented, just to let you know, aminoglycosides irreversibly bind. Aminoglycosides will irreversibly bind, meaning that tetracyclines reversibly bind. That's fine. One does, one is irreversible, the other one isn't. Whatever. Okay. Good. Great. I'm very happy about this. You guys are doing excellent. Okay. Let's move forward. Let's see here. Let's go with a lady voice. Lady's voice. All right. Let's go with Jen. Hey, Jen. You there, Doc? Jen, are you there?
Hello.
Hey. All right. Hey, Jen. How's it going, Doc? You hear me? You got it? You there? Jen? All right. Something happened over there. Oh yeah, that's right. That's right. You said that you weren't able to speak. Okay, so we're not gonna. That's fine. I'll move on to someone else then. That's fine. How about Chris Arelis? You there, Doc? You want to participate? Help a brother out? No. All right. Aisha. Well, I know you're gonna want to participate for sure, right?
Yes. Hello.
That's right, Aisha. Always can count on Aisha. All right, Aisha. Which enzyme is defective in this patient? And Aisha, I know you love how much you love biochem. So which enzyme is defective? Defective in this patient. 2-year-old boy comes in, brought in by his mom, concerned about an angry looking spot with drainage in the lower leg. Ew. That's interesting. The child has had multiple skin infections with staph, multiple skin infections since birth, and a pulmonary infection with aspergillus. That's a unique combination, right?
Catalase positive.
Say it again. Say it again.
Catalase positive organism.
You're so smart. He currently takes vitamins, no meds. Temperature's all right. Blood is okay. Blood pressure's okay. Pulse all right. Okay, labs are all right. Purulent skin lesion on the shin. That's cool. After biopsy, flow cytometry, neutrophils demonstrate lack of color change on dihydrotamine. Dihydrotamine has to turn green, and if it doesn't,
you are normal.
Dihydrotamine has to turn green.
Yes.
Normally, if it does not, you are abnormal.
Yeah.
All
You
right.
are sick.
You're sick. With what disease? What enzyme is defective?
DPH oxidase.
Look at that.
Yes.
Yes.
This, see?
Already there it is.
There it is, right there, clear as day. You had to know that staph and aspergillus were catalase positive. And there's another funky one that I've seen. Burkholderia. Burkholderia. Yeah. You're like, what? Okay. Yeah. Doesn't sound like something you want to have. I got that Burkholderia. Oh man. Does it itch? Oh yeah. All right. Very good, guys. Very good. Very good. So NADPH oxidase. Oh, by the way, G6PD deficiency is an X-linked recessive disease. Okay. It is X-linked recessive, and it actually reminds me of something I wanted to talk about earlier and I forgot about. It is X-linked recessive. Please learn your X-linked recessive diseases. Okay. There's only a handful of them, maybe 9 or 10. Please learn those. It's super high yield that you learn that those 6 or 7 diseases. But here's something I also wanted to show you. There was something I was trying to display here, and I kind of just got caught up with everything else. So notice what I did here. Notice how I put, let me see. Notice how I put substrate, rate limiting enzyme, and product. So for biochemistry, everyone, okay, I need you to, everybody, I need you to do this little assignment. In the first aid, there's a page in the metabolism section where they contain all the rate limiting enzymes. Okay, all there's like maybe 10 of them.
13.
All the rate say it again. 13 of them. Okay, good. So it contains the list of all the rate limiting enzymes. What I need you to do is I need you to add the initiating substrate, right? Who begins the pathway, and what's the end result? Okay. Please do so. Because, for example, if I were to ask, again, like I said, right, what do I need the HMP shunt for? I said I needed it for ribose 5-phosphate, so therefore I can get DNA synthesis or purines, right? So therefore that explains why, or actually, let me show you something here. Actually, I would rather just show it to you instead of explain it. Let me see if I can just move this up a little bit. There we go. Okay. So let's say I need ribose 5-phosphate, right, as my substrate to give me adenine and guanine. Does anyone know the rate limiting enzyme?
G6PD?
No. Not for.
Oh, not for that. I'm sorry. Is it the?
It's a funky one. It's all right. PRPP synthase or synthase. Okay. Great. So the idea of this is the idea. Your patient comes in and they have G6PD deficiency, which means my NADPH isn't working, which means they have catalase positive infections, which also means they're going to have trouble synthesizing adenine and guanine, which means they're going to have DNA issues as well. So what I want you to see is first of all, I need you to do this assignment. Do this because it will allow you to manipulate the information, and it makes you seem and appear like you know much more biochem than what you really do. Okay, trust me, I am not. I'm not trying to boast how much biochem I know, not by a long shot. Okay, but I do want you to at least know this. This is not a biochemistry exam, but at least know this because this allows you to maneuver between pathways. Okay. Sounds good?
You can find them in the page 75.
Page 75, everyone. Which first aid is this one?
It's in 73, like the first aid 19, but in the new one, 75.
Nice. All right. There it is, guys. Page 75 then.
2021?
Say it again?
No, 20.
Oh, in 2021.
2020?
2021.
2020. Sorry,
Okay,
2020.
Good. Okay. Excellent. So please do that assignment, everyone. Okay. Make that list. Have the 3 columns and maybe attach that list somewhere to your wall. Okay. Somewhere on the wall. All right. Very good. All right. Dr. CS. Dr. C and S.
Yes.
Let's get it in, Doc. Which of the following was the most likely original diagnosis 40 years ago? What did they diagnose this guy with 40 years ago? Okay. So here's the first thing I need you to understand. I may have mentioned this before. I'll mention it again. When it comes to media, right? So here they got a video. Media, labs, images, histo. We always leave that for last. Okay? We leave it for absolute last. All right, Dr. CS. Let's see what we got. We have 65-year-old man. He's been taking a medication for a chronic condition. Comes into the physician with the symptoms seen. All right. His original condition was diagnosed when he was 25, and he has been taking the same medication since 25, and he's now 65. So it's been quite some time. He states that these symptoms have developed gradually, and he's also noticed that he has begun taking short, quick steps when he walks. Oh, mask-like, expressionless face. Oh, focus. What is that?
Parkinson.
Parkinson's. Hey, doc. What did they give this patient that gave him Parkinson's? How about this? What is Parkinson's, doctora? Too much or too little? What?
Too little dopamine.
Nice. Too little dopamine.
Yes.
So then, what did they diagnose him with 40 years ago? They gave him something, and now he has Parkinson's, which means no dopamine.
Depression.
So he was
No.
depressed, and they gave him something that inhibited dopamine. Doesn't sound right.
Sorry.
That's a good question. I said again, I'll repeat again one more time. This is because you guys are overthinking.
Yes, this is related with that question that you explained about schizoaffective.
Oh, so what are you saying then, doc? Are you giving me an answer?
I would choose schizoaffective disorder.
All right, good. Thank you, gut.
yeah.
Thank you, gut. Shut up, brain. Thank you, gut. That brain always telling you, no, it can't be that easy. Shut up. Of course it can. I'm a damn doctor. What's wrong with you, brain? All right. So, schizoaffective, meaning they have schizophrenia. What's the problem with schizophrenia? Too much dopamine. How do you treat it? You decrease the dopamine. And what can happen if I decrease dopamine for too long? They get Parkinson's. Now, do you all want to see this 45-second video?
Nope.
No, I don't have 40 seconds to waste for them to show me the same Fernando from the last question. The same guy who was moving. Trust me, you're probably going to get the exact same image on your exam if they want to ask about Parkinson's. It's the same dude. Stevie J, that's him right there. Okay. So very nice. Very good. Okay. Very good. Schizoaffective. Okay, two other things. I just want to talk here about obsessive compulsive disorder versus personality. Obsessive compulsive disorder versus personality. I have obsessive compulsive personality, meaning things have to be a certain way. I want it like this. My pens are like this. Don't you touch them. I tell my wife, don't you touch my damn pens. My pens. I like them in a specific order. That's just my thing. I get really upset about it, right? That's obsessive compulsive personality. What's the disorder? A disorder is the person that you see turning on and off the lights for an hour and a half, right? Disorder is the person washing their hands for 4 hours. Okay?
It interferes with their daily life.
Exactly. It interferes with the daily life. Okay. A buzzword. Okay, just a buzzword. With. Let me see if I can type it up here. I'm sorry about that. Give me a second. How do I type here? A buzzword. Here it is. That I want you to remember what OCD versus OCP. Okay. OCP. Myself. Ego syntonic. My ego is in synchrony, meaning I know that I want my pens a certain way, and I'm okay with it. I don't care how it makes you feel. This is me. Okay? Versus ego dystonic, which means I know that I shouldn't be washing my hands for 3 hours, but I just can't help it. My ego is in desynchrony with my actions. Ego syntonic, I am in synchrony with the actions. I'm okay with it. It's all good. You know, some of you ladies, you want your pillows to be a certain way, 15 pillows on the bed. I don't know why, but it has to be a certain way, a certain design. Sure, that's a little OCP, ego syntonic. See? But OCD, again, dystonic, right? Combing their hair. I've seen this one. The girl combs her hair 15 times on the right, 12 times on the left. The child chews his food 30 times on the right, 12 times on the left. Like, yeah, that's definitely OCP.
With the disease?
The disease.
With the disease, you can't stop.
You can't stop. You can't stop.
And
that's
with
a problem.
the personality?
Yeah, you can stop. But it's just, that's the thing. It's a personality. That's just how it is. It's just, I tend to be a perfectionist. Things have to be a specific way, have to be right. That's OCP. Doesn't mean that there's a problem.
So is it, look, OCD, ego dystonic disease.
Disease.
How you get it? So I'm sick.
Exactly.
I'm ego dystonic.
Yep.
I have OCD.
OCD. Right. OCP is a good one. So if anything, it's just that two people in you know, pop culture, common knowledge say, oh, he got that OCD. He has OCD. No, he doesn't. Right? He just, why? Because he wants things a certain way. It doesn't mean that he or she has OCD. They just want things a certain way. That's it. OCD is when they can't stop. Okay, they can't stop. All right. Next one, ALS. All right. Everyone remember this? Was anybody one of those that participated in wetting themselves with ice water and recording it and then showing your friends all over the internet? Anybody? No?
No.
Must have been somebody. There was a bunch of people. Nobody in this group, right? Okay, good. Yeah, we don't have time to waste. Stupid. I'm gonna wet myself. ALS. You did nothing for it. You did nothing for it. You did. See?
Oh my God.
I'm like, I know somebody. There were so many videos. Like, by chance alone, somebody in this group had to have been.
I was trying to connect to my earpiece and I couldn't say it. I was like, let me just unmute this. Yeah, but I did. It was freezing cold.
Freezing cold. Great. I don't know how you helped the cause, but all right.
I don't know how I helped. I almost got
but in the moment, it was cool. Okay, so now look, that's good. So who has ALS, right? There was the world's smartest man, right? Stephen Hawking, infamous, right? The guy, I don't know if anybody was a fan of Big Bang Theory, but that was like their icon. This guy in a wheelchair, he didn't move, he didn't speak, but he would type on this little this little like device, looks like a calculator, and it would speak for him. Everybody remember that?
Yeah.
Remember that guy? Okay. He suffers from ALS. This is what I want you to remember about ALS. ALS is a movement disorder, not a sense disorder. Movement, not sense. They can't move, but they can feel. They can't move, but they can feel. Stephen Hawking was a married man. He can't move, but he can feel. I'm like, why would you be married if you can't move? Oh, because he can feel. Get it? Get it?
Yeah.
Okay.
Yeah,
Okay. Good. All right. Now, she might not be happy because he can't move, but he's happy because he can feel. Remember that one. That's how I remember ALS. Okay. So they're going to say something about sensory is intact, but they can't move. ALS. Okay, good. Next question. Let's see here. I want to go with Dr. Gustavo. Oh, come on, Gustavo,
hello.
hey,
how's it going, my friend?
Yes, man. It's been a while, man.
Yeah, man. Coming
Happy
back.
to hear you. Yes,
yeah.
Good.
Let's see.
I'll welcome you with open arms, my friend. Just come through. Yeah. We're here. All right. Let's do it, Doc. Which of the following contributes the most to the patient's symptoms? What symptoms?
Exactly.
All right. 40-year-old, disheveled African-American woman comes into the psych unit after police found her exhibiting bizarre and aggressive behavior in a public square. She's having conversations with herself, frequently giggles out of context. Sounds like some people I know. Which is hard to understand because she jumps from topic to topic in a scattered manner. The nurses report that the patient's behavior is childlike, with a tendency to expose herself. Oh, this girl. How old is she? 42? Shame on you. They are able to reach a family member who informs that that this started gradually about 7 months ago when she seemed to be talking to people who were not present in the room. What is this patient suffering from? Dr. Gustavo.
Schizophrenia.
Schizophrenia. Nice. Is this schizophrenia with positive symptoms or negative symptoms?
She has positive symptoms.
Positive symptoms.
But yeah, she doesn't have negatives.
What would be a negative? What would be a negative symptom?
When you something that you really like to do, when you remove normal behavior.
Okay, good. When you remove something normal. So the person used to talk with people, now is very withdrawn. They don't speak, they're somnolent, they're kind of off to the corner by themselves. You've seen these types of schizophrenics because they're the ones in movies, I've seen at least, that they tend to be the ones in their corner, quiet. They don't talk to nobody. That's just them. They're just always there in that corner.
Exactly.
That's a negative symptom. Hey, real quick. Doc Gus, do you remember which tract is associated with negative symptoms?
Which tract, you mean movies?
Which dopaminergic tract is associated with negative symptoms? Anyone?
I do. Mesocortical.
Mesocortical, very good. Mesocortical. All right, Dr. Gus. So you said the patient has schizophrenia. That means that this patient's symptoms are attributed to which of the following? What's the answer, Doc?
To an increase in dopamine. You just
Done. You see that? Very good. Very nice.
Three questions today around the same.
Yeah. Oh, see, but the thing is it though? It is, but it isn't, because this was endo, maybe it was psych, maybe it was neuro.
Yes, it's different presentation.
See that? And that's the beauty of this, of doing it in an organized fashion. That's the beauty of the schedule that I provided to you all. Because by doing it this way, you get to see the whole picture. You're like, oh, again? Yeah, again. Maybe it was a prolactin question. Maybe it was a dopamine question. Maybe a neuroanatomy question. You see, who knows? Could have been a farm question. You see? So could have been a biochem question, right? Because remember, tyrosine is needed to make dopamine and norepinephrine. So it could have been an amino acid biochem question. The thing is, if you understand the concept, i.e. the story, they can ask you from left, right, up, down. It don't matter. You're like, I know the story. Okay. Good. Nice job, Dr. Gus. All right. Let's see. Who else do we have here? All right. I have a phone number here. Last digits are 6,000. Dr. 6,000. Let's get it in. Are you there? Dr. 6000. You there? All right. Dr. Rod. Are you there? I see you. I see the name. Rod. You there? Anyone? All right. No Rod. All right. Then let's go to Jen. How about that one? Oh, that's right. Never mind, Jen. I forgot about you. All right. Oh, my goodness. What's going on today? You guys got nervous? All right. Dr. Joanna. Joanna F.
Yes, I'm here.
All right. Thank you. All right, Dr. Joanna, let's see here. Which of the following enzymes is deficient in this patient? All right. Let's find out. 24, African-American woman, intellectually disabled, comes in because we have severe chest pain and shortness of breath. Maybe an MI, but she's too young. She describes the pain as a stabbing sensation and points to the center of her chest. She's breathing and sweating heavily while seated on the exam table, and she's anxious. What do you think she's suffering from so far? Just based off of just the presentation alone.
Anxiety.
Say it again.
Anxiety.
Anxiety. Okay, I like that. Maybe. She reports that she's never seen a doctor. Vital signs: blood pressure a little high. We have a very tall, lanky body. Lenses are displaced downward.
Smartphone.
No.
Uh-oh, somebody said yes, somebody said no. What is it?
No, it's not Martian.
No.
It's not.
Smartphone is upward.
Yes,
Smartphone,
yes, you're right.
yeah.
Yes.
The
Down
lenses
is
are
hearing.
displayed
Down is
upward.
hearing. Almost incinuria.
Yes. That's what I'm talking about. Hell yeah, guys. Okay, so we have three guys. I call them the three basketball players, right? Three basketball players. If you think of a basketball player, for the most part, they all look more or less the same. Very tall, very long arms, maybe some tattoos, maybe dreads, maybe a short haircut. But for the most part, what differentiates them really? Maybe the team that they play for. That's really what differentiates, really, right? So if I say basketball player, like, oh, very tall guy, long arms, long legs, maybe a tattoo, right? We have three guys. Three guys. I remember this because there was like the triple threat in Miami, like LeBron, the other guy. I don't do basketball, but everybody kept talking about triple threat, Miami Heat, a little while ago. So that's where I came up with this. We have Marfan. That's number one. Clearly, Marfan has Marfans. We have homocystinuria, which is marfanoid. Marfanoid.
Mm-hmm.
Anyone remember the last one?
Habitus.
Say it. Say it again.
Habitus. Marfanoid habitus.
Well, yeah, but who else has marfanoid habitus? Who else? Homocystinuria, Marfan, and
oh my god, the
Fragile X.
Yeah, Fragile X. Clinical therapy. Okay. Ehlers-Danlos?
Nope.
Neurofibromatosis.
Nope.
No, neuromas.
Right, stop. Stop. You're done. Wrong.
Men too?
Men too.
That's what I'm saying. Because
Did you say that? Did you? I heard neurofibromas. I didn't hear you say men. I heard neurofibromas.
I forgot. Yeah, but I was
you
thinking
forgot.
it
I don't
was
care.
She was in the track. She was in the track.
She was on track with the specific details.
Yes.
Nice try. Good. So men to be. Men to be. Very good. So those are the three guys. Nice job. Nice job, everyone. Three guys that are all marfanoid. We just really got to figure out which one it is. Now, as Dr. Gustavo said, he's looking downward. Homocystinuria. Done. Then they say, what else? Where did we leave off? Tall, looking downward. Exam is unremarkable. No heart sounds. Increased breath sounds. Chest x-ray, nothing. ST segment, so heart disease, sure. And the deficiency of a particular enzyme that uses B6 as a cofactor. So somebody said homocystinuria. All right. So homocystinuria, what is it due to? Which enzyme is deficient? And for that reason, which enzyme is also dependent on vitamin B6 for homocystinuria?
B.
I don't know what that is.
Cystathione synthase.
Well, who said that? Who said that? Let me see. Who's saying that? Who's speaking?
I did, Joanna.
All right. Oh, all right, Joanna. All right, Doc. You are correct. Very good.
You scared me.
I'm like, I want to make sure. Good, because I've had some students. Oh, it's D. I'm like, yeah. How do you know? Well, it's not because I did the question a little earlier today. I'm like, yeah. So I want to make sure. It's not just I've done it before. But this is a nice way of remembering this, right? We have homocystinuria and homocysteine, and homocysteine wants to become cysteine or methionine. In order to become cysteine, the enzyme is going to contain the word cyst. Cystathionine, cysteine, cystadenone, what it says cyst. If it wants to become methionine, what do you think it's going to contain? M, right? Methyltransferase, methionine methyltransferase, MMT. So if it says homocystinuria, homocysteine can't get to cysteine, or homocysteine can't get to methionine. Now, what's the real kicker? Because it's not this, or this. Why was it cystathionine? Because I need B6 here, and then you double it up, and I need B12 here. Boom.
Oh, good.
See? Done.
My gosh.
Here's something else. You know our friend folate? Let's make it black. You know our friend folate?
Yes.
Yes.
Folate contains what's known as a methyl group attached to him. And we know that as long as something is methylated, it is muted, right? Methylated means muted, meaning it's not working. So we can't have this because, as you know, we need folate for DNA synthesis, right? Tetrahydrofolate, things like that. Right. So what is B12's job? Easy.
To methylate.
Yeah. Methylate who? Homocysteine. How? He is going to grab this methyl group. Actually, let me do it like this. I'm just gonna do this. Let's see, like so. He's gonna grab this methyl group and attach it to homocysteine, thus giving me methionine. And now folate is active. So can you see how if I have folate deficiency, I have DNA problems? Yes?
Yes.
Good. Can you see how if I have B12 deficiency, I also have folate and therefore DNA problems?
Yes.
See? There it is. It's just that B12 deficiency will present with homocystinuria. Oh, please know that. B12 deficiency can present with homocystinuria. Folate deficiency won't though. Okay. By the way, just to throw this out there, homocystinuria presents with multiple clot formations. So that's something else to also be on the lookout for. All right. Okay. This is good. We're almost done, guys. So far, so good. I hope everybody's, enjoying this, having a nice time today. Okay, Dr. Brenda. Let's go back to you, Dr. Brenda. Brenda J. Can't pronounce that last name. So I'm just gonna say Brenda. You there, Doc?
Yes.
All right. Which of the following should be rapidly administered to this patient? All right. What's going on here? I got a good concept for this one. Okay, what should be administered rapidly? Unresponsive 30-year-old man comes in, found alone, unconscious on the street. All right. Temperatures not too bad. Pulse is pretty low. Respirations are
6.
super
Very
low.
low.
Blood pressure is
Low.
nice. Pupils are
Small.
look at that. So is this patient having a lot of up or a lot of down symptoms?
A little down.
A lot of down symptoms. ER shows. Now, before we even start looking into the labs, based off of just this presentation plus the pupils, what do you think this patient overdosed on? You said it's a downer.
Opioids.
Opioids. Black tar, Afghan heroin. Oh yeah. Heroin. So if he overdosed on opioids, heroin, then what do you think you should give immediately?
Narcan.
Naloxone.
Look at that. Look at that. Look at that. Love it. Did we have to look at the labs?
No.
No.
Get out. Get
No.
out.
Okay. Now you could look at them and just confirm, well, if the patient's not breathing, well, he's not going to get rid of CO2, and therefore his CO2 increases, and therefore he now has a respiratory acidosis, as we can see here.
Yes.
See that? Perfect. Perfect. Everything else is normal. Everything else is normal. Sodium, borderline low, but everything else is fairly normal. Okay?
Yes.
So here's a concept. If a patient, let me see here. Okay. If a patient is taking a downer, okay, let me do this, toxicity and withdrawal. I want to talk about both of these. Okay, so if a patient is taking a downer, what will happen if they overdose? They'll have too much down, right?
Yes.
Okay, good. What happens if a patient has a withdrawal effect on a downer? So he's taking
too much up.
He's going to have too much up because, as you can see, the withdrawal is the opposite. Has anybody seen the movie Ray? I know a lot of us are Latinos, but some of us interested in that. No, Ray.
Oh.
Black jazz.
The blind guy.
Yeah. Jazz singer, piano player. Addicted to heroin. Did you know that? Did you know that? It's in the movie. The reason why I bring it up is because in the movie, okay, played by Jamie Foxx, there's a scene where he demonstrates what heroin withdrawal looks like. Okay, look it up on YouTube if you want to.
What is the name of the movie?
Ray. Ray, like Ray Charles. This is his name, Ray Charles. So R-A-Y with Jamie Foxx, blind guy. So you'll see that they have a lot of up as a withdrawal effect, meaning they're going to be sweating, they're going to be crying, leaking fluids, and very specifically, extreme abdominal pain and constipation to the point where you feel like you're going to die, but you don't die, which is unique about heroin withdrawal. You don't die from heroin withdrawal, but you will if you withdraw on alcohol. Because isn't alcohol also a downer? right?
Yes.
Okay. And if I withdraw on alcohol, don't they have something known as delirium tremens and seizures?
Yes.
Sounds like a lot of up to me. Yeah. All right. But if you take too much alcohol, which is a downer, and they overdose on alcohol, wouldn't that cause respiratory depression? Somnolence, bradycardia, things like that. Too much down. Okay. Cocaine is an upper. So then too much cocaine would cause psychosis,
Tachycardia.
insomnia, loss of appetite, right? Okay. Heart attack, MI. What do you think a withdrawal effect would cause if they're taking too much uppers? Down. So they're going to be sleeping all the time, eating all the time. See, slow. Okay. That's the concept I wanted to discuss with you all. I find this concept to be very, very important with psych. All right. Just think to yourself, is it too much up or too much down? What's going on here? All right. Good. All right, everyone. Last question. I appreciate you guys for being here. Today I wanted to extend it, make it a little bit longer today. Okay, so let's see. I am going to go with Dr. All right, V Boo. I haven't heard from you in a little while, Doc. You there?
Hello. Yep.
All right. Hey. All right, Doc. Let's see. We got a drug here. We're talking about drugs, which describes the MOA of the drug used to treat the patient's acute findings. What findings are we talking about? And then what drug was given?
Okay.
Let's see. 39. Rigid muscles, mental status change. Okay. Evaluated by the psychiatrist a month ago, reports that he was locking himself in the apartment because the devil was trying to put thoughts into his head. Right? Doesn't that feel like y'all sometimes? Always trying to put these negative thoughts like it can't be that easy. It can't be that simple. No. It has to be more complicated. Choose the bottom answer. No, just choose B just because. Damn devil. Yeah. Right? He initially responded well to pharmacologic treatment and was able to resume normal daily activities, but developed acute symptoms this week. Temperature is super high. Pulse is super high. Respirations are borderline high. Blood pressure is super duper high. And they gave him something. So what's going on, Dr. Boo?
Okay, so I always get stuck between malignant hyperthermia and serotonin syndrome.
Okay.
So this one, it looks like he was schizophrenic. They gave him antipsychotics. So that's going to be the neuro.
Say it. Don't fight it. Say it. Shut up, brain. Think you got
hypertension, whatever it's called.
Nice. So neuroleptic malignant syndrome. Very good.
Thank you.
Good. All right, Doc. MOA of the drug used to treat. What drug do I use?
So for that, you give dantrolene, right?
Dantrolene. How does dantrolene work?
So dantrolene is going to mess with calcium.
Nice. Which of the following answers mention anything about calcium?
Okay, so no E. D mentions it. C doesn't. D2, no. And no. So D looks like they're the answer.
Great job. Dantrolene. Now, I'm actually glad that you brought this up. Okay, that you're saying that you had an issue mixing the two. So
yeah.
Neuroleptic malignant syndrome and malignant hyperthermia are one and the same, kind of, sort of. Now, that's like me telling my wife that Coca-Cola and Pepsi are the same shit. It's the same thing. For me, it's the same. But I'm sure you Pepsi lovers or you Coca-Cola lovers say, no, they're very different. I'm like, look, with some rum, it all tastes the same. Okay? It all tastes the same, as far as I'm concerned. Neuroleptic malignant syndrome and malignant hyperthermia, same thing. Pepsi, Coca-Cola, it's the same thing. Neuroleptic malignant syndrome, you get it after taking antipsychotics. Okay, cool, which is what happened here. Malignant hyperthermia, you get it after taking anesthetics. So somebody who's undergone some surgery. Let's say they gave them succinylcholine, and now they got this malignant hyperthermia. Either way, I'm still going to give them dantrolene. Either way, they're still going to be very rigid. And because they're so rigid, they're going to be very, very hot. You see? So Coca-Cola or Pepsi? It's the same thing. As long as it's not Czech Cola. Right. Everybody got that? Understanding the reference? Okay. Now, Dr. Boo, you said you had an issue with serotonin syndrome. If we go back, to our notes earlier.
Do you say hyperthermia maligna is for prescribing too much what?
Anesthetics, after a patient has undergone anesthesia, after being given anesthesia for surgery. Yeah. So Dr. Boo, remember what we said about serotonin? We said he is sympathetic and parasympathetic. So then what do you think serotonin syndrome is going to present? How do you think serotonin is going to present?
It's going to be sympathetic up in the brain and down in the
Exactly.
PNS.
So if you see a combination of up and down, tachycardia with bradycardia, hypertension and hypotension, hyperthermia with hypothermia, vasoconstriction with vasodilation, you're like, huh, that's called autonomic instability. The things that should be, that autonomic instability is what should be automatic is not automatic. Autonomic means automatic. Autonomic means automatic. So autonomic instability means automatic. All your automatics are off. Heart's going all over the place. Blood pressure's all over the place. Okay. That combination is classically seen with serotonin syndrome. And usually that's the patient who takes the MAOIs and mixes it with serotonin. All right. Got it, everyone?
Mm-hmm.
Yep. Yes. Yes, yes, yes.
Yes.
Yeah, that cleared it up. Thank you.
Good. Very good. Okay. Bueno, everyone. This was fun. Let's see here. Cool. I'll take it. 100%.